Finals SAQ10, one lung ventilation. A. What are the indications for one lung ventilation? 30 marks. Indications for OLV includes isolation of the lung to prevent cross-contamination, such as in empyema, massive hemorrhage, and lavage. Secondly, to control distribution of ventilation, such as in unilateral bronchopleural fistula, unilateral lung pathology if life-threatening hypoxia, unilateral airway damage, or unilateral cyst. Third is to facilitate surgery. One lung ventilation enables adequate exposure of the lungs and mediastinum, which is required for thoracoscopic surgery, esophagectomy, pneumonectomy, lobectomy, scoliosis surgery, etc. OLV enables unilateral lung lavage, such as for alveolar proteinosis. B. How can the risk associated with lung resection be quantified preoperatively? 30 marks. Risk assessment is based upon history, examination, assessment of functional status, calculation of thoraco score, spirometry, tests of diffusion capacity such as DLCO, etc. A multidisciplinary team approach is appropriate, involving the patient, anesthetist, surgeon, clinical nurse specialist, respiratory physician, radiologist, and other members. The thoraco score gives an estimate of mortality risk based on a number of variables such as demographics, degree of dyspnea, comorbidities, performance status, and type of surgery. Calculate the predicted post-operative PPO, FEV1, and DLCO. First measure FEV1 and DLCO. PPO, FEV1, and DLCO is based on anatomic calculation, VQ scans, or CT evaluation. An example of a formula for anatomic calculation is PPO equals preoperative value times 19 minus number of segments resected divided by 19. Predicted post-operative FEV1 and DLCO. If both are more than 60%, the patient is low risk. If both are 30 to 60%, proceed to stair climb or shuttle walk assessment. If good performance, the patient is low risk. If poor performance, proceed to cardiopulmonary exercise testing, CPET. If PPO, FEV1, and DLCO are less than 30%, proceed to CPET. Proceed with cardiopulmonary exercise testing if PPO, FEV1, or DLCO are less than 30%. Poor performance on stair climb or shuttle walk assessment. High risk according to cardiac evaluation, including thoracic revised cardiac risk index score. If VO2 max is 10 to 15 mL per kg per minute, the patient is moderate risk and should have post-operative HDU admission. If VO2 max is less than 10 mL per kg per minute, the patient is high risk and surgery may not be appropriate. Overall, the patient may be classified as clinically fit with good exercise tolerance and normal spirometry. Accept these patients for surgery. If there are major medical problems, minimal exercise capacity, and grossly impaired pulmonary function tests, consider alternative treatment. If there are reduced exercise capacity, abnormal spirometry, with or without moderate coexisting disease, proceed with further assessment and careful evaluation of risks and benefits of surgery. C. How would you manage the development of hypoxaemia during one lung ventilation? 40 marks. Declare emergency situation, alert the theatre team, request for help, conduct simultaneous assessment and management of the patient, follow an ABC approach. Considerations include severity, rate of change, and stage of surgery. Airway. Provide 100% oxygen. Take over manual ventilation of the patient. Check for obvious equipment failure such as disconnection. Check for disconnection at wall, cylinder, ventilator, or tubing. Check for double lumen tube or bronchial blocker dislodgement. Confirm capnography. Check for secretions or blood that have occluded the tube. Use bronchoscope to assess and clear secretions if necessary. Look for carina, trachealis, and bronchial cuff or blocker. B. Breathing. Assess for compliance, capnography waveform, and oxygen saturations. Auscultate the chest, if feasible while the patient is straight, and consider bronchospasm, pneumothorax of the ventilated lung, and inadequate paralysis. C. Circulation. Assess for cardiovascular stability, check for sources of bleeding, manage accordingly. For example, using fluids, blood products, vasopressors, inotropes, and stopping the source of bleeding. If assessment is otherwise normal, the likely cause is abnormal lung physiology caused by one lung ventilation. Options to manage hypoxia include the following: CPAP or high-frequency oscillatory ventilation to the non-ventilated lung. This reduces shunt effect caused by ongoing perfusion to the non-ventilated lung. An example for CPAP settings is 100% oxygen with 5 cm H2O. Second option is intermittent two-lung ventilation. However, ask permission from the surgeon. The third option is high-frequency jet ventilation of both lungs. This is not an option if there is need for complete lung collapse or if there are concerns about cross-contamination. Fourth option is early clamping of pulmonary artery to non-ventilated lung to resolve shunt issues if the surgery is for pneumonectomy. Fifth option is to increase PEEP to the ventilated dependent lung. This is to counteract the effect of mediastinal weight on the functional residual capacity in the lateral position. The next option is to reduce PEEP to reduce possible compression of pulmonary capillaries by excessive intra-alveolar pressure. Increased airway pressure to ventilated lung may help to ensure adequate tidal volume. However, excessive airway pressures risk impairing perfusion. Increasing eye time may improve hypoxemia. Tolerate increases in PaCO2 associated with increased eye time. Optimize cardiac output and hemoglobin to ensure oxygen delivery. This does not improve hypoxia but mitigates its effects. Switching to propofol TIVA can be considered to improve hypoxic pulmonary vasoconstriction. Additional information. Risk factors for hypoxemia during one lung ventilation includes old age, lung disease, right lung operation, supine position, hypoxia preoperatively, and hypoxia pre-isolation. Causes of hypoxemia during one lung ventilation: low PiO2, hypoventilation due to pressure limitation, VQ inequality, HPV is impaired by general anesthesia, and shunt, upper lung perfused but not ventilated, HPV impaired by general anesthesia, usually 25% blood flow to upper lung and 75% to lower lung.